Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. If you have osteoarthritis in one of your knees, how do you know if it's time for a knee replacement? And is a total knee replacement better than a partial knee replacement? Today, I'm talking about this with Dr. Robert Sherman. He's an assistant professor of orthopedic surgery at Upstate. Welcome back to The Informed Patient, Dr. Sherman.
Thank you so much for having me today.
Now, how common is osteoarthritis in the knee? Is this something we're all going to get?
It is extremely common. And no, we're not all going to get it, but many of us have it and many of us that don't will get it. Arthritis in general is a relatively complex problem in why some people get it and why other people don't. But what it means basically is that the joint surface at any joint has worn off. In a joint, you have a thick layer of cartilage on the two bones that make up the joint. And that smooth surface allows the two bones to bend and twist and move against each other without any pain or any restriction. Unfortunately, due to genetics, due to environment, injuries we may have suffered when we were teenagers or in our 20s and 30s, and just due to life itself, people's cartilage wears down. And we are all mammals, so we do not have the capability of building that cartilage up. One of the most common locations that we get symptoms of arthritis is the knee.
And is this wear and tear? I'm just wondering, someone who's been very active, using their joints, moving around a lot like a professional athlete versus the couch potato, is that any insurance against developing osteoarthritis?
Unfortunately, it's not. So there's a huge genetic factor, which we don't have a great understanding yet. So if mom and dad had arthritis and your siblings had arthritis and your grandparents ended up with joint replacements or your aunts and uncles ended up with joint replacements, you're unfortunately already predestined to have a higher risk of arthritis. The other part is environment, which is injuries. Injuries play a big role. Life plays a big role. Overweight plays a big role. When you don't have any symptoms, the sport activities, the running and the jumping really doesn't matter. And honestly, even the weight doesn't matter if you don't have any arthritis. But years of the pounding of the joints, unfortunately, results in injury to the cartilage. And as that cartilage becomes thinner and more dysfunctional, those activities now actually injure it even more, whether it's just overuse, whether it's high impact sport, or whether it's being overweight, leads to more damage to the cartilage and eventually to the development of symptoms.
Do you see osteoarthritis in both men and women equally?
It's very common in men and women. We see it in both genders, in active patients, in non-active patients, in patients that worked for years on hard floors, and patients that didn't do those activities. It affects almost everybody.
Are most of your patients older?
The ages are all over the place. So the simple answer to that question is yes. I mean, if you are in your 80s and 90s, it's more likely than not that you do have arthritis. But we see it in younger and younger patients as well. So in my practice, which concentrates primarily on arthritis and on joint replacements, I have patients on average from their late 40s all the way up into their hundreds. But every once in a while, I'll get that 25-year-old patient who had an ACL injury in high school, who had surgery, who then retore their ACL, who then had another injury or maybe fractured their femur bone or their tibia bone. And now even in their early 20s, they've already developed severe arthritis.
So how would a patient know that they have osteoarthritis? And how do you go about diagnosing it?
So the typical presentation is that somebody comes in and says, my knee hurts. It swells, it locks, it catches, it sticks, it aches. It wakes me up at night, or maybe it doesn't bother me at night. It's worse when I'm on my feet for a long period of time. Or in many cases, it doesn't bother you while you're doing that activity, but after you sit down for an hour or two and then you go stand up to go get something to eat or drink, you feel like you're Frankenstein. You can't move. It's stiff and it aches. that can be a lot of different things. That doesn't mean you have arthritis or osteoarthritis, but that's a common presentation of that. The diagnosis is made primarily with X-ray. So X-ray takes an image of the knee, and what we're looking for is the space between the femur bone and the tibia bone, or the kneecap bone, the patella bone, and the femur. And as the cartilage thins, that space gets thinner and thinner. We've all heard the term bone on bone, and what bone on bone means, it's a layman term, it's not a medical term, but what it means is that you've worn off so much of the cartilage that on an X-ray, it looks like the two bones are touching. In a normal joint, there's a space there because that space is filled with cartilage. But as that space wears, it actually gets to a point where the bone is touching. And in severe cases, it actually erodes into the bone. And you'll see people walking around with very knock-kneed knees or very bow-legged knees. And that's very common to see in somebody with severe arthritis because they've worn out one part of their knee more than the other. And now not only is it bone on bone, but as we lose more bone, the knee now starts looking either knock-kneed or bow-legged.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with orthopedic surgeon Robert Sherman about options for treating osteoarthritis in the knee. Now, I know we're going to be talking about the replacement options, but before you get to surgery, are there things that you recommend people to do that can relieve knee pain?
There's a lot of things we do. Surgery is always the treatment of last resort. Unfortunately, surgery always comes with some risks, and surgery, of course, comes with a recovery. So we do not jump into surgery, and I never recommend surgery as the first line treatment, except for very, very rare situations. So what do? We see a patient in the office, they have symptoms. Their knees ache, they hurt, they swell, they lock. There's a lot of different things that we can do. We start very simple, the lowest risk, the easiest things to do, and then we work their way up. Some of the first things that you can do are modify your activities. It sounds silly, but it's very successful. Don't do the things that hurt. If it hurts when you run, but nothing else bothers you, maybe try the elliptical, maybe try swimming, maybe try a bike. Try to get that cardiovascular exercise, which is so important for your health, but not doing it at the expense of hurting your knees. Try taking Tylenol or nonsteroidal anti-inflammatory like Motrin or Aleve. These can help the symptoms. It's probably not the best thing to take it 4 times a day, every day for 40 years, because they do have side effects, but to take it intermittently on a bad day is very safe unless you have certain risk factors like liver disease or kidney disease. So it is important that you talk to your primary care doctor about it. But if you don't have those risk factors, taking those medications as needed can help your symptoms a lot. In acute flares, so with arthritis, you might all of a sudden, whether it's weather related, and yes, if you have bad arthritis, you might be the best weatherman in the world. You know when that cold front's coming in. A lot of people don't believe it, but there's some truth to that. So, if you're having a bad day, a day of rest is not the end of the world. Take it easy. Resting every day is a bad thing. Just sitting on the couch and stop moving is not a good solution. But on a bad day, taking it easy is a good thing. Using ice to help swelling can help. Using heat to help muscle aches can help. So that if we look at our athletes, they'll warm up with heating pads and then they'll cool down with ice. That's exactly what you want to do. The heat helps the muscle. The ice helps the swelling and the joint pain. There's braces that can be used. So if you're a little bit knock-kneed or a little bit bow-legged, wearing a brace to help straighten the knee out can help. There's other braces that just provide some compression around the knee that will decrease some of the swelling and they'll help the symptoms as well. We'll often do injections. There's a cortisone injection. That's a steroid that the doctor can inject into the knee joint to decrease swelling and decrease inflammation and decrease pain. It tends to result in improvement in pain and symptoms for 6 to 12 weeks. You can get a lot longer. I have patients that swear by it for years, and you might not get more than a couple days, but the average person gets about 3 months of relief with a cortisone shot. There's other injections with something that people often call gels or hyaluronic acid. These are medications such as Synvisc and Orthovisc and Gel 1 and Hyligan and Monovisc. There's a lot of different ones on the market. And these are hyaluronic acid. These are the building blocks of cartilage. They're marketed as a cushion to the joint. That's not actually how they work. It's unfortunately a shame in how they were marketed. But what they do is they bind to the cells that line the inside part of your knees that cause the inflammation to get your body to actually make less inflammation, resulting in less pain. The advantage of this over the cortisone is when these injections work, they tend to provide more often 3 to 6 months of relief instead of only 6 to 12 weeks of relief. But they often, like other injections, don't work as well. And the first injection tends to work better than the second injection and better than the third injection. There are other situations where physical therapy can be very beneficial. In situations where patients are weak and stiff, that can help regain flexibility and that can help regain muscle strength, which helps with mobility significantly. There's some newer procedures that are being done more and more frequently. There's a procedure called genicular nerve ablation, and there's a nerve in the back of your knee called the genicular nerve. And in that nerve runs a lot of the pain fibers that go up through your spinal cord to your brain. There's not a lot of motor fibers or sensory fibers. So motor fibers make your muscles move. Sensory fibers give you feeling on your skin. So this nerve doesn't have many of those nerves. It's almost all the pain nerves only. So if you disrupt that nerve, it often hurts less without developing any weakness and without developing any numbness. So there's some newer procedures where you try to interrupt that nerve with either medications, using heat, something called radiofrequency ablation, radiation therapy, to go in and disrupt that nerve so that you don't sense the pain anymore. It doesn't fix anything, but your knee doesn't hurt as much anymore. And that's been very successful in many cases as well. In very rare situations, we start talking about a surgery called arthroscopy or scoping a joint, where we go in with a camera through a tiny little incision and then put some tools through a tiny little incision, and we can smooth out the cartilage or we can trim the meniscus. This is not very successful in arthritis, but in the precursors to arthritis, when people have knee pain and mechanical symptoms of walking and catching without severe arthritis, can be very successful in improving your symptoms and hopefully resulting in less likelihood that you'll end up with severe arthritis. When you've tried either some or all of these different avenues to try to make the symptoms tolerable, but the symptoms are not tolerable, that's when we start talking about joint replacement. Typically, the patient that comes in for a joint replacement has tried many of these things. You don't have to try all of them, but they've tried many of these things. And despite that, they struggle walking a quarter of a mile without a cane or without pain. They struggle with day-to-day activities, and they struggle with something that we call their activities of daily living, which is the simple things like bathing, dressing, cooking, shopping. And then obviously they struggle with sport and leisure activities as well. And when those symptoms interfere with your day enough, that's when we start talking about, is it time for a joint replacement?
Can you explain the difference between partial and total knee replacements?
So in order to explain the difference between a partial and a total, I got to take one step back and talk a little bit about how the knee works. So the knee is a very interesting joint in your body. If you think about your knee, it bends and straightens, so it acts like a hinge, but it also rotates and you can move side to side. So there's a lot of different motions that your knee can do. The knee has 3 compartments, 3 areas of where the bone rubs up against each other. There's this space between the femur bone and the tibia bone. The femur bone is the thigh bone, and the tibia bone is the shin bone. And there's the inside part of that and the outside part of that. We call the inside medial and the outside lateral. So there's 2 different joint spaces between the thigh bone and the shin bone. And then there's a second joint or third joint between the kneecap and the femur bone. When multiple areas are bone on bone and symptomatic, when we talk about joint replacement, we talk about a total joint replacement so that it can address multiple of these joints. A partial replacement is when you only have arthritis in one of these three areas. So if it's just really bad on the inside part of your knee or the outside part of the knee or the kneecap, we can do a surgery that tends to be a little bit easier recovery, feels a little bit more natural, and only replace that single compartment. There's some advantages of this, but unfortunately, there's also some disadvantages. Regardless of whether it's a full total knee replacement or a partial knee replacement, what we do in a knee replacement involves removing a small wafer of bone off the femur, but if it's between the femur and the tibia, so a small wafer of bone off the femur and a corresponding small wafer of bone off the tibia, and taking a metal cap made out of different materials, often made out of either a metal called cobalt chrome or titanium or oxinium, which are the three most common materials used, and putting that on the end of the bone. So you now have a new surface made out of that material. And on the tibia bone, putting a metal piece similarly into the bone where you've removed that small wafer of bone, and then putting a piece of plastic between the two pieces. In a full knee replacement, we remove the entire top of the tibia bone and the entire surface of the end of your femur. It's not a lot of bone that we remove. We only remove about 1/4 of an inch or 1/3 of an inch of bone, but we remove the entirety of the tibia, the femur, and then a small wafer off the bottom surface of your kneecap. In a partial knee replacement, we take off about the same amount of bone, but we just do a small segment of it, whether it's the femur and tibia on the inside, the femur or tibia on the outside, or the kneecap and the femur.
So it sounds like you rely on the anatomy and the x-rays to help you determine whether to recommend a partial or a total.
The x-rays are very important, but the physical exam is very important, and the patient's symptoms are very important. So you might see a patient whose x-rays only show arthritis on the inside part of their knee. But when you ask them, where do you hurt? They grab their whole knee and they say, it hurts everywhere, doc. It hurts in the front. It hurts in the back. It hurts down my leg. That's probably not the best patient to do a partial knee replacement on, because if we make their pain better on the inside, what's not to say that pain's coming from the other parts of their knee? So the patient that I like to do a partial knee replacement does the one finger test. When I say, where does it hurt? They point to one spot in their knee, and that happens to be the spot on their x-rays that shows a lot of arthritis. And then the rest of their x-rays shows no arthritis. Oftentimes we'll get an MRI of their knee ahead of time to help make this diagnosis as well. Because to be a good candidate for a partial knee replacement, you need to make sure that all the ligaments in the knee are working well. There's 4 major ligaments in the knee. Most people have heard of at least one of them, which is your ACL. Anybody that watched any football this year knows that the football players are tearing their ACLs left and right this year. So to be a candidate for a partial knee, you need to have a good working ACL, a good working PCL, which is the counterpart to the ACL, and a good working MCL and LCL. These are the ligaments that are on the outside part of our knee. So if the ACL is torn, you're not a good candidate for a partial knee replacement. So you can make that diagnosis on exam, making sure the patient doesn't have any instability. That can be tricky in an arthritic patient because their knees are stiff. So it's hard to feel the instability of a torn ligament. So we'll often get an MRI to confirm that the arthritis is really only in one compartment and that the ligaments are working well.
What about the strength of bones? If someone has a calcium deficiency or something like that, does that mean that you can't do the surgery because you rely on those bones to anchor the replacement, right?
We do. And if we look at who has joint replacements, they tend to be older and they tend to have medical conditions. We're not doing a lot of joint replacement on healthy teens and 20 and 30-year-olds. They tend to be people more commonly in their 60s, 70s, 80s, and 90s. So we just assume that everybody has the worst possible bone ever. But in patients that really do have a lot of osteoporosis and bad bone quality, there's a higher rate of complications. There's a higher rate that we could break the bone during surgery, or a higher rate that the pieces that we put in might fail and collapse. Sometimes in those patients, we're more concerned about doing a partial knee replacement because there's less surface area for the implant to rest on the bone. And if their bone's poor quality, you get worried that it might move position. But the vast majority of people, despite severe osteoporosis, are still candidates for either a full knee or a partial knee.
What are the replacement pieces made of? And have you ever seen a person react negatively or their body react negatively to the implant?
The most common material is a metal called cobalt chrome. And this is almost like a stainless steel. It's made out of cobalt, chromium, molybdenum, and a little bit of nickel. Titanium is a great strong metal as well, but the problem with titanium is it's very soft. If anybody has titanium jewelry, they'll know that it's relatively easy to get a scratch in the titanium. So we get worried about using titanium because if you get a scratch on this cap that's on the end of your femur bone and it's rubbing on a piece of plastic, that scratch will continue to wear the plastic over and over again, and the knee will fail. So for a long time, we were very concerned about using titanium. More recently, we've noticed that people might have an allergy to nickel. And a lot of people, especially women, will come in and say that when they wear cheap jewelry, they break out in a rash. Watches can cause them to break out in a rash, earrings, things such as that. Now, a localized skin reaction to most commonly nickel is what we think is what people are reacting to. Doesn't translate to a true allergy deep in your bone. But we get worried about that patient population that brings that up. There are a couple labs across the country that can do specific blood testing looking for true allergies. So there's one big lab based out of Chicago called Orthopedic Analysis, and you can do a study where they send a kit to your house and you go to your doctor, we draw blood and we send it back. And they actually give you this really nice report to all the different implants that we can use and whether you have any true reactivity. So in patients that really are allergic or have a reactivity to nickel, not just the rash, but demonstrate true reactivity, we wanted to come up with other materials. And one manufacturer came up with a material called oxinium, and that is a oxidized zirconium. So like a cubic zirconium, but it's oxidized. And it has very, very, very low percentages of nickel in it. So that company, a lot of people started using that to avoid the nickel issue. It still has some nickel in it. So the other companies came up with a way of using titanium because titanium is a very inert metal and it's extremely unlikely the body will react to it in anybody. I already mentioned that the problem with titanium is it's soft and we worried it might scratch. But they came up with a special method where they can oxidize the titanium and make at least the surface of it very hard and polished so that you now have a titanium implant with a hard surface on the end of it that won't scratch. So at least two companies that I can think of, Zimmer and Stryker, have come up with these titanium ones, but there's probably other companies that have their version of that as well. And that's what I typically use in patients that are really allergic to the nickel.
You're listening to Upstate's The Informed Patient podcast with your host, Amber Smith. My guest is orthopedic surgeon Robert Sherman, and we're talking about options for treating osteoarthritis in the knee. Are the total and the partial knee replacements meant to be lasting for life, or how common is it that they need to be redone?
So I tell my patients with a partial knee, the goal is about 15 to 20 years. And with a total knee, the goal is about 20 to 30 years. And like everything in life, the outcomes of these implants are a bell curve, right? So there are some that fail very early for a lot of different reasons within the first couple of years. And then the majority of people get, like what I mentioned, about 15 years out of a partial knee and more like 20 to 30 years out of a full knee. The reason why the partial knees fail quicker is because most people will develop arthritis in those other areas of their knee that when we did their surgery 10 or 15 years earlier, didn't have any arthritis under the kneecap. didn't have any arthritis on the outside part of their knee. Maybe their ACL was working well 15 years ago, but now it isn't. So they fail for that reason. And that's why it's more common to have to go back and redo it. When a partial knee fails, the surgery to fix it is relatively straightforward. You just basically go in and make it a full knee. And the recovery and the risks really are no more severe than doing the full knee in the first place. So there's not really a harm in doing a partial knee replacement, because if you get 10 or 15 years out of it, and maybe you're 40 years old or 50 years old, and that can get you to 65 or 70. And then when we convert it over to a full knee, you'll get to 100, and then you'll just need 2 knee replacements. The full knees, when they fail, it might just be the plastic wears out. And that's a really easy fix. You just open it up, clean it out, and put a new plastic in. Or maybe the metal has failed as well, and that's a little bit more complex. And you have to remove the worn out metal and put a new piece of metal in. That's a little bit more complex surgery.
Is it common for someone who has a knee replacement to later need the other knee replaced as well?
From a statistical standpoint, there's a relatively high rate if you have arthritis in one body part that you're going to end up in another one, and it's often the same. So whether it's one shoulder than the other, or an ankle or a knee or a hip, but it doesn't always work out that way. There are lots of patients that, for whatever reason, it's all on one side of the body. Their right knee, their right hip, their right ankle, their right shoulder, their right elbow all wear out, and nothing on the left.
Well, before we wrap up, I want to ask you about what life is like for patients with a replacement in terms of, can they get back to mountain climbing and running and doing the things they used to do? Or will the replacement part affect their gait?
So once you have a replacement, whether it's a partial or a full knee, your knee is always different. The goal of the surgery is one and one only, which is to make it stop hurting. Now, the advantage of a partial knee replacement is that it tends to feel a little bit more natural. In a partial knee replacement, we leave your ACL ligament, so the way that the bones interact and they slide across each other feels more like a natural knee. So you tend to get a little more range of motion with a partial knee over a full knee. But most importantly, it feels a little bit more natural. So there's two patient populations that I tend to really recommend the partial knee, is that younger patient in their 40s and early 50s, and then maybe that second group, which are in their 80s or 90s, because the recovery is a little bit easier from a partial knee. So if you're 85 years old and you only get 15 years out of it, that still gets you to 100, and that might be enough. If you're in your 60s, 70s, early 80s, and you're really debating whether should we do a partial or a full, I tend to recommend a full in those patients, just because we know that one is probably going to last enough where they'll never need a second surgery. And if they do the partial, they're more likely to need a second surgery. But to answer your question a little bit more detailed, what is life like after you have a joint replacement, whether it's a partial or a total? There are changes. Joint replacements tend to feel clunky. They tend to feel mechanical. They tend to feel foreign. They don't feel like a natural knee. Hip replacements are way better as far as feeling natural. Most patients that have a hip replacement will say, I must forget I had surgery. You don't ever get there with a knee replacement, whether it's a partial or a full. I feel so much better than I did before surgery, doc, but it still feels like the knee that I had replaced. That's a very common thing that patients will tell me. But it allows activities that most people couldn't do before their replacement because they were in so much pain. So walking and biking and swimming and tennis and golf and gentle hiking are all activities that you should be able to get back to. You do want to avoid the impact activities. These are not designed for running and jumping and twisting and pivoting. They're not designed for contact sports. Unfortunately, my residents don't know who this famous athlete is anymore, but hopefully most of your listeners will remember Bo Jackson, right? Bo knows. And he had a hip replacement, a little bit different than a knee replacement. He tried to get back to playing professional football. It wasn't going to happen, right? You just can't do that with a joint replacement. He even tried to get back to playing professional baseball, and that didn't really happen either for him. You just couldn't do those activities with a joint replacement. There are been some athletes that get back to certain activities. I think, I forget his name. There was a Tour de France cyclist that had a joint replacement in the knee that I think got back to it. But that's relatively rare. They're not made for that high impact activity. They're not made for sport. They're not made for running and jumping. But normal everyday activities. I want to go on a walk. I want to go play golf. I want to be able to go shopping. I want to be able to do life and not have the pain that is disabling before surgery. Knee replacement is a fabulous option to allow you to do those activities.
Well, this has been very informative. I thank you for making time for this interview, Dr. Sherman.
Well, thank you so much. And I'm so happy I had this opportunity to talk to people.
My guest has been Dr. Robert Sherman, an assistant professor of orthopedic surgery at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.